Again, thank you for having me here. It's quite an honor to be here and speak with you today about some oculoplastic cases that have some systemic implications. And so one of the most important things that I want to remind the audience is that although we are ophthalmologists, we are also physicians, which means that we actually have to take care of the entire patient, not just the eye. And there are many ophthalmic findings that can be suggestive of systemic disease, and I'm going to present some of them to you today. And it's imperative that the ophthalmologist identifies these, as they can be sometimes the first manifestation of systemic illnesses that may have some dire consequences if not caught early. So I'm going to start with case number 1, which is a 2-year-old boy that was referred to the Bascom Palmer emergency room for me to evaluate with a 6-month history of left lower lid swelling. And the child had been followed by his pediatrician and was diagnosed as having a chalazion. There was a slight increase in size. The child had no significant past medical history. His review of systems were negative. His mother denied any fever, no weight loss, no night sweats, no changes in energy. And this is a photo of the child's eye, and you can see that the left lower lid is quite swollen. There's maybe a little bit of a left lower lid ectropion as well. But on examination, his vision, pupils, pressure, all were normal. He had some slight limitation to abduction on the left eye. His anterior segment, posterior segment were also normal. But when palpating his left lower lid, you could feel a very firm nodule extending to the orbital rim and the lateral aspect of the upper lid. There was no lymphadenopathy appreciated on his neck or in his preauricular area. So we had a CT scan performed that was brought to us from the outside hospital. And I have a few cuts here showing you coronal view that demonstrates an infiltrate along the superior temporal orbit extending down into the lower lid that's fairly large. As a matter of fact, if you really pay close attention, you can also appreciate that there may be some of the same findings located on the right eye as well, though the child was asymptomatic on the right. And I also have some axial views to give you a little bit more appreciation of the lesion here in the superior temporal orbit, and maybe a little bit in the superior temporal orbit on the right side as well. So we had the patient undergo preoperative evaluation with chemistries that were normal, a CBC that was normal, his PTT was also within normal limits. And the differential diagnosis that we were entertaining included rhabdomyosarcoma, metastatic neuroblastoma, a chloroma, also known as a granulocytic sarcoma, lymphoma, which is fairly rare in children, orbital inflammatory pseudotumor, or a histiocytic lesion. And so a biopsy was performed, and although this doesn't show it very well, you can see that there are some atypical immature lymphocytes with these arrows pointing to, which is basically pointing to a diagnosis of a granulocytic sarcoma or chloroma. And it's given the name because of its greenish hue, which it obtains from myeloperoxidase, and is a harbinger of leukemia, basically AML, ALL, CML, or CLL, and requires a prompt referral to an oncologist for performance of a bone marrow biopsy. It typically is seen in males more than females in the first decade of life and carries a very poor prognosis with a death at a median age of 1.5 years of diagnosis of the orbital disease. Imaging findings typically show a predilection for a bone and periosteum, with the lateral orbital wall being more commonly involved than the medial orbital wall. The CT scan, as I showed you, is very homogeneous and iso-intense to the extraocular muscles. And MRI can show similar findings as well, iso-intensity on T1 and T2 to the extraocular muscles with enhancement on gadolinium. So when it comes to leukemia, there are a lot of other ophthalmic clues that you probably are all aware of. For example, conjunctival pallor can be noted because these patients are often anemic. They may have a pseudohypopyon if their eye is involved, as well as milky iris lesions, which I'm showing you here. You may also notice subconjunctival and retinal hemorrhages, and you may see Roth spots on dilated fundus exam, as noted here as well. Choroidal infiltrates can be noted, as can optic nerve infiltration, which is denoted in this picture up in the top right. Other systemic clues include multiple bruises because their coagulation cascade is probably not an ideal situation. They can have excessive bleeding, lymphadenopathy and splenomegaly, and gingival hyperplasia. So this child was referred immediately to the pediatric oncologist, where the bone marrow biopsy confirmed an acute lymphoblastic leukemia, which had not been manifest in his blood work early on, and he was started with chemotherapy and radiation, but unfortunately, the child passed away. And so the take-home point here is that while we know that orbital disease can provide insight to a systemic process, the lack of recognition led to delayed treatment of vital therapy, and that was a delay of about 6 months that may have changed the outcome for this poor child. Case number 2 is a 55-year-old male who presented with left eye pain and worsening vision on the left eye for the last 4 days. He denied redness or proptosis and had no prior episodes of ophthalmic issues. His vision on the right eye was 4/200 with no improvement on pinhole, and his intraocular pressures were normal. He had an afferent pupillary defect in the left eye, and his ocular adnexa was normal without proptosis or ptosis or enophthalmos. Here's a fundus photo of his right eye and a fundus photo of his left eye. And what you can see on the left side here is basically a diffuse optic nerve edema with a lot of sludging and engorgement of the retinal veins, along with hemorrhage along the superior arcades with some dot blot hemorrhages diffusely as well. An MRI shows enhancement in the level of the optic nerve on the left, much more so than the right. And I have to be honest, I did have some history with him. He was diagnosed as having a non-secretory multiple myeloma with progressive worsening of his systemic disease despite chemotherapy. He also had been treated with autologous stem cell transplantation 2 months prior to the presentation. So I did know that in the back of my head. But we ended up getting serial MRIs on him until we finally decided to pursue a left optic nerve biopsy. And so on biopsy, what we notice here is a proliferation of lymphoplasmacytic cells, and I'm going to give you a little bit magnification, that have a very high nuclear to cytoplasmic ratio as identified by all this blue, which is typically a bad sign. And the final diagnosis in this case was multiple myeloma with secondary extramedullary plasmacytoma of the optic nerve. And multiple myeloma within the orbit can present as 3 different entities. You can have a plasmacytoma of the bone, you can have an extramedullary plasmacytoma, or it can manifest as necrobiotic xanthogranuloma, which may have some other systemic findings as noted by these lesions on the patient's face. Usually the patients with necrobiotic xanthogranuloma may have a monoclonal gammopathy in 80%, or 10% of them may have underlying multiple myeloma. With regards to orbital multiple myeloma, 1/3 of the patients had orbital involvement as their initial presentation, while most of them had already carried a previous diagnosis. And the average time from diagnosis of the orbital involvement to manifestation was around 18 months for those who had orbital involvement first, with proptosis being the main presenting symptom, followed by decreased vision, diplopia, and ptosis. The location of these typically is seen in the superior temporal orbit. This was by a study by Kat Burkhat in 2009, who looked at multiple cases reported in the literature. Most of the orbital lesions are going to be posterior as opposed to anterior, and extraconal as compared to intraconal. And these are more often unilateral than bilateral. And there's a common progression of tumor from surrounding bone to the soft tissue. Interestingly, however, the involvement of the orbit did not necessarily portend a different long-term survival as compared to patients with multiple myeloma without orbital involvement. The treatment typically involves radiation to the orbital lesions along with chemotherapy and stem cell transplantation or plasmapheresis for patients with hyperviscosity. So this patient underwent 5 cycles of XRT for the plasmacytoma and was followed by a medical center closer to home. Within the next month, he developed lesions in the spine and brain, which eventually led to respiratory failure and an untimely death. Case number 3 is a 61-year-old pilot presenting with acute proptosis in the left eye and blurred vision in the right eye. He woke up suddenly one day with a swollen left eye and mild pain associated with this. He has a very insignificant past medical history of hypertension and hyperlipidemia. His mother died from complications of childbirth. She'd had 11 children. His sister died from stomach cancer. His medications were Crestor, Candesartan, and bisoprolol. His vitals were within normal limits. His vision was 20/40 on the right and 20/20 on the left. He had no afferent pupillary defect. His intraocular pressures were normal. Gonioscopy was normal. And I'll show you some more pictures of his adnexa. He had no obvious ophthalmic or orbital bruits. His anterior segment was within normal limits, and his posterior segment is as follows. So here is photos of his adnexa showing him in various positions of gaze. And you can notice the proptosis much more readily on down gaze, where you can see fullness in his superior sulcus. His ductions, however, are fairly full. This is the eye that does not have proptosis. Actually, what you can notice is there are a lot of cotton wool spots and hemorrhages consistent with a branch retinal vein occlusion. MRI was performed, and here are some coronal views that I'm going to highlight for you some important findings. One would be this very large circular lesion that's present on the left side but not seen on the right side. And you can see that it's fairly heterogeneous with some enhancement along the peripheral aspect of it. I also have axial views showing the same thing. Here you can see the structure enlarged and widened, whereas fairly normal on the other side. And here is sagittal views showing you more of the same thing, with the extent going from behind the globe almost to the apex. So the diagnosis here was a right branch retinal vein occlusion with a left superior ophthalmic vein thrombosis. And so superior ophthalmic vein thrombosis usually are going to give you some ophthalmic signs secondary to the elevated episcleral venous pressure. They may have a slightly higher intraocular pressure, and if it's really high, you will see some blood in Schlemm's canal on gonioscopy. They can have dilation and tortuosity of conjunctival vessels, proptosis, and dilation of the retinal veins. And superior ophthalmic vein thromboses are very rare in isolation, but some possible etiologies, the most common ones are probably an orbital infection or an inflammation. It can also result from a spontaneous closure of a dural sinus fistula, which in these cases they're usually self-limiting, or it can be a result of a hypercoagulable state. So just to give you a little review on hypercoagulable states, you know, we were taught in medical school about Virchow's triad, Virchow being a very famous German physician who's the father of modern pathology. And his triad includes stasis, hypercoagulable state, and endothelial damage as risk factors for clot formation. We have antithrombotic factors in our bloodstream, including protein C, S, antithrombin 3, and plasmin. We have prothrombotic factors, including prothrombin, factors 5, 8, 9, 11, and fibrinogen. And it's interesting to understand that 12% of patients who have idiopathic or unknown causes of a DVT are found to have a malignancy. So it's important to make sure that these patients have updated breast, colorectal, and possibly even prostate screening. With regards to hypercoagulable states, they can be acquired or inherited. And acquired usually results from patients who are immobilized, sick chronically in the hospital with CHF or other issues. They can have had surgery, which is a pro-inflammatory state. It could be due to hormones like oral contraceptive pills, pregnancies, or even nephrotic syndrome from loss of all these proteins that are pro-anticoagulants. It can be inherited, and the common ones include activated protein C resistance, which is also known as factor V Leiden, hyperhomocystinemia, protein CNS deficiency, antithrombin 3 deficiency, or even the prothrombin gene mutation. And treating DVTs are very interesting as well. You really want to tailor your length of treatment according to the patient. So typically your first DVT, you anticoagulate the patient for 3 to 6 months. You consider lifelong anticoagulation for patients with a DVT without any identifiable risk factors, or if they've had recurrent DVTs, a symptomatic pulmonary embolism, an underlying active malignancy, or an underlying hypercoagulable state like antiphospholipid antibody syndrome. Your options for treatment include anticoagulation with vitamin K antagonists like Humidin, a direct thrombin inhibitor like Xarelto or Eliquis, factor Xa inhibitors like Pradaxa. Antiplatelet therapy, interesting, doesn't have a role for active DVT, but may help prevent recurrence. So going back to this case, he has no recent long flights, no tobacco use. He has no medications that kind of are prothrombotic, no atrial fibrillation examination. He doesn't have any evidence of proptosis on old photos, which rules out the possibility of a spontaneous closure of a dural sinus fistula. So we referred to hematology for an anticoagulation initiation on Lovenox, which was bridging him through to Coumadin, and did a very extensive workup for all the possible hypercoagulable states we could think of, all of which came back negative. And interestingly, 3 weeks after starting his Lovenox and bridging him to Coumadin, his ocular symptoms improved significantly. You can see that his proptosis has resolved, and his motility is also intact. And here's a before and after showing some of the findings a little bit more easily for you. So his workup is still ongoing for less common clotting factors, and he actually went back to the Bahamas and never returned to us, so hopefully he's doing well. So I'm going to actually skip all the way to the end and skip my last case, which was Muir-Torre syndrome, but just conclude with a couple of things. One, orbital disease does provide insight to systemic processes. Two, a delay in recognition leads to a delay in treatment, and that could be the difference between life and death. Thank you so much.